let's talk about a couple of very practical issues. The first is a patient who's had prior cetuximab, and now you're thinking about immunotherapy in the form of an anti-PD-1. Is there a reason?
Yeah, so there was subgroup analyses that were presented at ASCO this year, looking within CheckMate 141 at those patients who had previous treatment with cetuximab. It should be noted that prior treatment with cetuximab did not negate the ability to give cetuximab as an investigator's choice, but that was a very small subgroup of the patients on the trial. And those patients who had been previously treated with cetuximab, the incremental benefit to the nivolumab was much diminished. And that's quite notable because really what you're then ended up comparing it to is you're comparing nivolumab to patients who largely received docetaxel and methotrexate. One of the things that's interesting about CheckMate 141 is the most common drug that was given on investigator's choice was methotrexate. And so when you're comparing nivolumab, which we're establishing as a highly active drug, to mostly methotrexate, and you're not seeing a survival benefit or a much diminished one, that's really confusing. And I don't know exactly how to interpret that information.
So you've said a number of dismissive things about methotrexate over the course of the morning here, and I just want to point out that the hopes of gefitinib and zalifrelimab and a number of other agents kind of foundered on the fact that methotrexate does have some activity. And there's some responders and there's some people who don't progress immediately.
Not an inactive drug.
Not an inactive drug.
When you're getting into deep salvage, patients do tolerate it pretty well other than mucositis. So for that patient that's been repeatedly chemosensitive, that has received their PD-1, that has received platinum, taxane, 5-FU, maybe doesn't have trials available, it's an active option, but it's maybe not quite the paradigm of chemotherapy that we reach to first or consider many. I think it's controversial for many whether this should be a standard that another drug like afatinib or nivolumab really should be compared to.
And getting back to nivolumab and pembrolizumab, again, very, very practical. You have now a choice of either one. Jared, which one or what do you choose when you've got a patient who's a good candidate for an anti-PD-1 immunotherapy? Which one do you go to?
So, we've spoken about many controversial topics today and had a nice spectrum of opinions here. For me, this is the question on which I have the least passion of any question you've asked any of us today. So, to my mind, in the existing data, the toxicity, safety, and efficacy of these agents appear far more similar. You might have reason to torture slight differences in cross-trial comparisons. You certainly could talk about the way the trials were done. Those decisions, there are differences. There's no good reason to see these as dramatically different agents, in my opinion. So what are you left with? What you're left with is that nivolumab is an every 2-week drug, or at least it currently is. In my practice, my median travel distance is quite long. It's 3 or 4 hours for local reasons. And when that's the case, for me, that creates a strong driver to give an every 3-week drug. And for me, that's the main differentiator. But if one of you said, hey, I really like nivolumab, I've had more experience with it, I've been on trials, I wouldn't criticize that in any way.
Any differences of opinion there?
No.
Very, very similar. More similarities than differences between the two drugs. Well, what about the choices between an EGFR targeted agent, chemotherapy, and immunotherapy? I'll go around. Josh, what factors in there?
If I have a patient who has previously failed platinum, then I will preferentially use immunotherapy prior to a drug like cetuximab or other cytotoxic chemotherapy based upon the toxicity and the activity profile.
Barbara?
So if I have a patient who is highly symptomatic, bulky disease, mass near the airway, something like that, and we're in frontline, even if we're within 6 months of radiation, the response rates to chemotherapy are a little bit higher, and I think those are patients who need a response. The other group where I'm a little reluctant about using a PD-1 inhibitor fresh out of the gate is the ones who are PD-L1 non-expressing, less than 1% on tumor and tumor-associated immune cells, because that's a group, albeit you can see responses, the response rate is low, and the overwhelming majority of them progress right away. So I still feel that there are people with bleeding risk or bulky mass or a lot of symptoms who are going to do well with chemotherapy and cetuximab for some time, and who are probably going to do well with an IO agent down the road. But I agree with what Josh said earlier, that the sooner we can get to a multiplexed kind of predictive model that might include HPV status, tumor bulk, PD-L1 expression, tumor infiltrating lymphocytes, and mutational load. I mean, there are a lot of interferon response gene signature. There are a lot of candidates here, but I think that it would be great to have that.
Jared, what factors into your decision?
So, like the rest of the panel, my preferred treatment option is a clinical trial. In the absence of that, say that we can't have that, then I use these for the most part as indicated, which is to say that in a platinum-sensitive first-line patient, a platinum-containing first-line agent regimen remains my standard of care. One thing I would say about that is that I do have very strong feelings about the extreme regimen as written, that the toxicity is a little bit extreme. And while I know others may have differences of opinion, my personal opinion is that the toxicity in that regimen is excessive for a population whose primary goal is palliation. And so we didn't talk much about alternative induction regimens, some of those weekly schedules, but there are a series now, more than a half dozen phase 2 trials looking at the strategy of weekly carboplatin with a weekly taxane and a targeted agent, usually cetuximab, that show response rates in the 60 to 93% range, that show very acceptable toxicity profiles, consistently superior to what was seen in the extreme regimen of cisplatin 5-FU and cetuximab. And I have wholesale, I will confess on the record that I have wholesale moved away from the standard of care regimen of cisplatin 5-FU cetuximab, that I just can't stomach doing that to patients. And I will routinely use one of these weekly schedules for the first-line patients when I choose chemo. I happen to like carboplatin, nab-paclitaxel, and cetuximab, but there are multiple variants that people use that tend to have the theme of platinum taxane plus or minus EGFR targeted agent that I think are a little more humane. So in my practice, I'm sticking to the label in the sense that if they're platinum sensitive, I'm using some chemo combination first, but I'm diverging quite a bit from that label in using an alternative cytotoxic regimen when I do. And then I'm having a lower threshold perhaps than before the PD-L1 agents to declare failure on that regimen. Whereas before I might have watched and seen a pace of growth and considered other things, I have a lower threshold now with a more effective second-line agent to move on to a PD-1 agent. I really want to guarantee the patient a shot at the durable control that these agents offer, and so I have a lower threshold to call progression than I might have in the